Thank you so much. So I'm excited to talk with you all about the management of venous thromboembolic disease because there's some new information, some cutting-edge things, and so it's a pretty exciting topic to be able to discuss with you this morning or this afternoon. So I do want to start out by polling the audience a little bit just to get you warmed up here to talk about this topic. Which of the following signs or symptoms are statistically found to correlate most with a diagnosis of pulmonary embolism? Dyspnea, hemoptysis, and fever, tachypnea, dyspnea, and pleuritic chest pain, cough, and fever, or hypotension, chest pain, and diaphoresis. So I'll give you all a second here to respond. And I would agree with the majority of the audience. And I'm impressed because oftentimes I think some of our workup gets limited when someone is not hypoxic. So we're calling that the primary statistically found symptoms that correlate most with this, or tachypnea, dyspnea, and pleuritic chest pain, are excellent, that 95% of you know, and now the rest do as well. So which of the following diagnostic tests are used in the initial evaluation of a suspected DVT in a patient with a low pretest probability? Is it ultrasound, venography, D-dimer, or CBC? Okay, so D-dimer is the correct answer here, although you're not wrong if you say ultrasound, but we'll talk a little bit about how we decide whether or not to pursue which test and which one we go to first. So the objectives are that we're going to talk about the statistics and epidemiology. I want to talk about the basic workup for a patient who presents with VTE, talk about the initial pharmacologic management of both processes, discuss the indications for non-pharmacologic treatments. We're going to talk about that just a little bit because the majority of patients will be treated with pharmacologic management. And then at the very end, we'll get into non-vitamin K oral anticoagulants, which we'll refer to as NOACs for the rest of this discussion. So the epidemiology for VTE, it's actually the third most common cardiovascular disease after MI and stroke. And the perfect storm will oftentimes be when these patients present with an acute clot. So those are patients who have both acquired and genetic risk factors, and we'll talk a little bit about what those risk factors are in a minute. But it is interesting to note that the majority of patients who present with stable PEs have a mortality rate of 15%, which is not really that high. But patients who present with unstable PEs at 3 months follow-up were statistically found to have a 60% risk of mortality, which is quite high. And all of the other factors that played a role in that, patients who had underlying malignancy, congestive heart failure, RV failure, pulmonary hypertension, or who were elderly, all had an increased risk of mortality. So I thought it would be best to go through this presentation by following a patient that I took care of on the hospital medicine service a few years ago. This was a 76-year-old female who walked into the emergency room and told us that she had had a Nissen 3 weeks prior. She had had an uneventful postoperative course, but had developed acute dyspnea and pleuritic chest pain when she ambulated, and then she presented to the emergency room for evaluation. So her vital signs, you can show or see that she had some tachypnea, some tachycardia. She was hypertensive. And in looking back on her prior records before she left the hospital, before she left, she had had baseline O2 sats of 97 on her MER. Currently, she's hypoxic and requiring 3 liters to maintain her sats above 90%. Her past medical history, what is notable here is that she has a history of a DVT, and she would tell you that she had a DVT after one of her deliveries after she had delivered one of her babies years prior. On a physical exam, you find that she's in moderate respiratory distress. Not surprising, since we note that she's tachypnic and she's tachycardic. And on her laboratory studies, you find that her troponin's a little bit elevated, but it's reassuring that her BUN and creatinine are normal. Her EKG shows some non-specific ST changes, not something uncommon we see in patients with PE, but she does have some sinus tachycardia as well. And her chest X-ray shows some mild bibasilar atelectasis. So you're asked to admit her to the hospital, and as you're going down to admit her, you're starting to think, okay, what's my differential diagnosis, and how am I going to work this patient up? So we can't really talk any further about VTE without bringing up Virchow's triad. And this triad is something you probably remember from PA school, but this is the perfect storm of when a patient is likely to develop a VTE. And usually, studies show that at least 90% of patients have one risk factor, if not more. So her underlying risk factors would be that she was likely hypercoagulable and immobile following her surgery. She also had some vessel wall injury because she had some surgery as well. So we don't know if she has an underlying hypercoagulable state, but she does meet at least one, she does have at least one risk factor, which would correlate with the studies that show that most patients have at least one. So what are our risk factors? Well, medical and surgical patients have a higher percentage of risk recurrence, and that percentage is fairly wide, 10 to 80%, based on their underlying comorbidities. That's why the variance is so wide there. But even with prophylaxis, risk is up to 10% of patients during and after their ICU stay. I work in a pulmonary critical care department now, and we are very, very hesitant to take patients off of pharmacologic prophylaxis for VTE because the risk is so high. The risk of recurrence is highest in patients who have an active malignancy, in patients who have antiphospholipid antibody syndrome or any of the inherited thrombophilias, and men are also at increased risk. So this is not a comprehensive list of risk factors by any means, but it does highlight some of the most common ones, and those are catheters, history of VTE, which I highlighted because this fits the history with our patient, underlying hypercoagulable states, which we'll talk about in a little bit, malignancy, obesity, estrogen replacement in high doses is a risk factor for VTE, patients who have had traumas, and warfarin, this is more of a theoretical risk, but patients in their initial phases of warfarin treatment do get depletion of protein CNS, so there theoretically is an increased risk of warfarin in the initial days of treatment. So acute VTE presentation. Now, some patients will present and they have no symptoms at all. Other patients, you'll see that they're in cardiopulmonary collapse and shock. So remembering the triad of dyspnea, pleuritic chest pain, and tachypnea is important, but also to remember that there can be extremity pain and swelling in patients who have who have underlying DVT. The Homan sign is not very specific. So clinical suspicion is what cues you into your diagnosis as you're working into your working that patient up in your initial stages of their presentation. So I do want to note that there is a process called Phlegmon ceruleum dolans, and I've never seen this in my practice, but it is when a patient presents with an acute onset of a massive DVT, and the venous occlusion is so obstructive that it actually causes arterial occlusion. Those are patients that come in with the, quote, blue painful leg. So I've never seen that, but it does exist, and maybe a board question or something, you may be able to see that at some point and diagnose that patient if they come in with that kind of finding. All right, so let's go into how we evaluate patients with acute VTE. Well, the diagnosis is made on clinical suspicion and diagnostic studies, but also there have been some scoring systems that have been validated in the literature, and currently the Wells criteria takes more of a common, I think it's more of a predominantly used scoring system because the American College of Chest Physicians uses that more than they use the Geneva score. So we're going to talk about the Wells criteria because that currently is what's recommended by the American College of Chest Physicians. Now, the Wells criteria was validated by one of the landmark studies that were used to look at PEs, and that was the PIOPED study. There's 3 in total. PIOPED 1 and 2 is what looked at Wells criteria. Now, Wells criteria was developed for risk stratification and to aid you as you decided where along the pathway you were going to start ordering a D-dimer, an ultrasound, a CT scan, etc. And it's available. There's 2 different scoring systems. One's for DVT and the other one's for PE. So you calculate a Wells score, and you can access this by typing, you can use MD Calc to get to a Wells score that you can calculate off of, doing a Google search or whatnot. But you look at their clinical findings and then assign them a point based on their clinical findings. So then after you total all their points, they're divided into categories of being low probability, moderate probability, or high probability. And for PE, the process is the same. You look at their clinical findings, assign them a point system, and then assign them a probability score. So for our patient who's coming in with tachycardia, a history of recent surgery, and a history of DVT, we would assign her 6 points for her Wells score, which would put her at high probability for PE. So here's a question for you. This is a 67-year-old female who comes to the emergency room with episodic chest pain, which is worsened with inspiration and also with movement. Now, her initial EKG and chest x-ray and enzymes are negative, and her pulse oximetry shows that her sats are 94% in room air. Her blood pressure is a little bit high, 185/96, and her respiratory rate is 18. Her physical exam's unrevealing. And here's the clinchers. She has no history of DVT, no surgery, no recent surgery, no cancer history, and no prolonged periods of immobility recently. She also has no prior history of VTE. So based on the Wells criteria, which of the following best describes the pretest probability? And that's right. It would be low probability. Good job. All right. So while we're thinking about low probabilities, we're going to talk about D-dimer. And a D-dimer is a quantitative test that has a high negative predictive value. So it helps you when it's negative, and it doesn't necessarily help you when it's positive. Now, being on the ICU side now, I rarely ever order D-dimers because my patients have had stays in the hospital over 100 days and have been in and out of surgery and have a bunch of reasons to have an elevated D-dimer. But when you're looking at a patient who should have a negative D-dimer, then it's very helpful because the judicious use of it when it's used has a very low likelihood of a VTE. So you assign your patient a probability score. They have a low or moderate probability score. A D-dimer is a reasonable option. And if it's negative with a 99% negative predictive value, you've ruled out an underlying VTE. Okay, the other option for the evaluation of an acute VTE is an ultrasound with Doppler, and that's indicated in patients who fall into 3 categories. They could be your patients who have a high pretest probability of DVT, a moderate pretest probability with a moderate sensitivity D-dimer, or patients who have a positive D-dimer. Now, the ultrasound is less sensitive if the DVT is only in the calf, but if you have a symptomatic thrombosis of a proximal lower extremity DVT, an ultrasound is around 90% for both sensitivity and specificity. So you're not wrong if you get an ultrasound, but the literature right now would say if they have a low to moderate probability, you start with a D-dimer, you go to an ultrasound if they're high probability. So this is just an algorithm of what we've just discussed. If your patient has a D-dimer that's negative, you've excluded DVT. If it's positive, they warrant further workup. And if you go towards the ultrasound, it's diagnostic, you have a diagnosis if it's positive. If it's negative, you could perform a D-dimer if you need reassurance. Otherwise, you would repeat an ultrasound in 1 week if you have a high suspicion and the ultrasound is negative. So other diagnostic studies that are available for DVT are a computed tomographic venography, contrast venography, magnetic resonance venography. These are all options, but contrast venography, previously the gold standard, is invasive, technical, operator dependent, not widely used since there's other options available. And computed CT venography can be used, diagnostically equivalent to a Doppler ultrasound, and it's non-invasive, so that is also an option. So let's talk about thrombophilia. So this is something that always comes up when someone comes into the hospital or presents to the emergency room with a DVT and PE. And the question is, should I order a thrombophilia panel? Now, thrombophilia panels are recommended, and these are recommendations from the American College of Chest Physicians, if the patient does not have any known reason to have a clot and is younger than 50. If they've had a recurrent VTE and no diagnosis of malignancy, or if they have first-degree family members with a documented VTE. So if you order a thrombophilia panel, you'll get it probably does vary by hospital, but majority of hospitals, I'm sure, you may have to add these on, I'm not sure how that works, but at our hospital, we would get protein CNS included in the thrombophilia panel, antithrombin, factor V Leiden, prothrombin gene mutation, and antiphospholipid antibody syndrome. I think the caveat to take home from thinking about getting a thrombophilia panel is that you have to perform this before the treatment is initiated or after the clot has been treated. And the reason for this is because clots and treatment can alter the laboratory values for protein CNS, antithrombin, and if they have an acquired antithrombin problem, can alter that as well. So use caution when ordering this. Typically, I have, if the patient has a PCP, contacted the PCP, let them know that we're initiating treatment, and then once the treatment is completed, the PCP is aware and can work them up for thrombophilia. If the patient doesn't have a PCP, talking to hematology and getting them in after the patient leaves the hospital is also a reasonable alternative. But we don't make it, I never made it a habit. The providers in my practice, the physicians I've worked with, never really used thrombophilia panels in the inpatient setting very often. Okay, so which of the following conditions are indications for thrombophilia testing? According to the College of Chest Physicians, idiopathic VTE before age 40 is correct. All right, so why do we treat DVTs? So DVTs are treated to stop the clot from propagating, to prevent recurrence of the clot, and also to prevent PE. So those are our goals in initiating treatment when we're starting someone who comes in with a DVT on anticoagulation. So the question does come up at times, who do we admit to the hospital? Well, patients who have threatened venous gangrene or extensive thrombosis, those would be your patients who would present with that phlegmon ceruleum dolans we've seen before. Has anyone ever seen that before? I'm just curious. You have. Was it impressive? Oh, what ended up happening? Okay, I'm sorry about that. Okay, so inpatient management would be people who have threatened venous gangrene or extensive thrombosis, or patients who are being considered for thrombectomy or thrombolytics. Outpatient, the majority of your patients can be discharged from the emergency room, providing that they have follow-up and that they're stable patients with a relatively low bleeding risk. Now understand, no patient's going to have now a super low bleeding risk that you're starting because you're starting them on anticoagulation. But these are your patients that you see who come in, who have a DVT, who are stable, look stable, have a low bleeding risk, and are patients who you're reassured are going to follow up and be compliant and whatnot. So treatment recommendations. So we typically will start patients on an IV infusion of unfractionated heparin versus Lovenox, followed by the initiation of warfarin. And we would initiate warfarin the night that we started them on IV heparin or Lovenox, with adjustment for their INR goal to get it between 2 and 3. The other option we have now are NOACs, rivaroxaban, apixaban, adoxaban, and dabigatran. And there's also another one called alpha-denosant that is currently not FDA approved, so we're not going to talk about that, but maybe next year we'll be able to. These are our options now for treating DVT. So we prefer to use Lovenox over IV unfractionated heparin in patients who are pregnant or patients who have an underlying malignancy. The American College of Chest Physicians recommends that Lovenox should be used to treat patients who have cancer. Lovenox has to be reconsidered in patients who have renal impairment. They do require a dose adjustment and monitoring of their creatinine. And also patients who are underweight, they have increased risks of bleeding, so Lovenox may not be the appropriate medication for them. And you also remember low molecular weight heparin is a heparin product. So if the patient has any history of HIT, it's an absolute contraindication to starting them on Lovenox. The alternative is weight-based fixed dosing of sub-Q heparin, and I have not done this a lot, but in the patients I've done it with, it's usually been under the direction of a hematologist, but that also is an option. So some pearls to remember with Lovenox. So Lovenox dosing recommendations for DVT, you have two options. You can use 1 milligram per kilogram twice daily dosing, or 1.5 milligrams per kilogram daily. With PEs, you're stuck. Those patients will need BID dosing. So it's sometimes more convenient for the patient, and maybe it will increase their compliance if you're dosing it once a day. If they have DVTs, you can do that. Again, if they have PEs, you're limited to twice daily dosing, 1 milligram per kilogram. Lovenox should overlap warfarin initiation for a minimum of 5 days or until their INR is greater than 2 for 24 hours. This is, again, according to the College of Chest Physicians, but I do understand that there will be some providers that may want them on they may want them therapeutic for more than 24 hours. It's provider dependent, but according to the recommendations, they don't really need to be on it for more than 24 hours. The thing to remember is that there are still high copays with a lot of insurances for Lovenox, so enlist help early if you're going to need to get prior auth. You don't want your patient walking out of the emergency room or the hospital with a copayment that they can't afford. So I just want to talk about low molecular weight heparin failure because I think it's really fascinating. And I've seen this a few times, although it's not common, but usually it's because the patient's not compliant. But I also have seen it where the patient had gained an extraordinary amount of weight over a 3 to 4 month period, and therefore their weight-based dosing of Lovenox was no longer adequate for them. So that is something that I always think about now when I think of someone coming in with a clot that's propagated or recurrent clot while they're on Lovenox. You can use anti-factor 10A assays, but these need to be collected prior to additional heparin administration, which is sometimes difficult to do because by the time you see the patient's already been given further heparin by the emergency room physician or whatnot. So it's sometimes hard to interpret that. And you also have to interpret it with what time they dose their Lovenox at and whatnot, because it varies based on what time you're drawing it and what time they dose themselves. But it can be helpful for determining if the level was appropriate, if it's done right, and also if the patient is taking the medication at all. Someone who truly does have failure with Lovenox, you need to rule out HIT as a therapeutic adverse reaction. So that would be like a HIT-induced thrombosis. And also the bottom line take-home point with this is to determine if there's cancer recurrence or if there's progression of an underlying malignancy. Okay, that's going to be the most common reason for true Lovenox failure. Now the treatment duration is easy because we just have to memorize one treatment duration slide for both DVT and PE. So patients, the underlying etiology is what determines how long you're going to treat the patient for. So IV unfractionated heparin or Lovenox for 5 days and a stable INR greater than 2 is what we go to now, but again, NOACs are an option. So talking a little bit about treatment duration here. So first episode, reversible cause, be it surgery or a transient risk factor. Pregnancy would be a transient risk factor. If they're on estrogen replacement, taking them off of it, and then that would be another transient risk factor. Flying, flights greater than 8 hours is what I have literature to support their increased risk of clotting. Those would all be examples of transient risk factors. And whether they have a DVT or a PE, 3 months is the recommended treatment duration. First episode, idiopathic cause. So we don't know why that patient clotted, but it is their first episode. Those are going to be patients who get treated for at least 3 months' time. And extended therapy is recommended unless there's a concern for bleeding. Now, unprovoked recurrent VTE or ongoing risk factors, those are going to be patients who warrant long-term anticoagulation. And we do have to weigh the risk of bleeding with the risk of thrombosis, but that will be an ongoing issue for however long they're on anticoagulation for. Now, you probably see the bullet point here down here. If anticoagulation is stopped, aspirin is not considered to be an acceptable alternative to anticoagulation. But the American College of Chest Physicians currently says that if the anticoagulation is stopped, start aspirin unless there's a substantial bleeding risk. So it's not an alternative to treatment, but should the patient decide they no longer want to be on anticoagulation or their risk with anticoagulation is too great in terms of bleeding, aspirin is what they recommend starting. Now, post-thrombotic syndrome, previously we gave patients compression stockings when they came in with DVTs just to help with pain and swelling. And that's really where we're at right now. If they have pain and swelling and it's something that's helping with their symptoms, you can give them compression stockings. But previously they said you had to wear them for 2 years or your risk for post-thrombotic syndrome would go up. And now the chest guidelines say they're not really sure that that had anything to do with why they had ongoing symptoms. So routine use it can be used if patients have symptoms. That's the bottom line. But post-thrombotic syndrome, elevate the limb. They can get up and walk as tolerated. I know years ago that was always seemed to be a question. Can I get this from the nurses? Can I get this patient up? Can they walk? Is it safe to do that? And they can get up and walk if they tolerate it. Again, if they have severe pain and swelling and whatnot, then they shouldn't. So, okay, so evaluation of acute PE. The first question to ask ourselves is the patient stable or are they unstable? And we do that by looking at their vital signs, their blood pressure, their pulse, their respirations, and their mental status. So if your patient is profoundly hypoxemic, they're probably not going to have a normal mental status, then that patient would not have a stable PE. If they are stable, you can start your secondary assessment. That includes things like your EKG and your radiologic studies, etc. But if they're unstable, that's when you're going to be calling the ICU and talking about possible thrombolytic therapy, and we're going to be considering whether or not we should start the patient on pressors. Now, back to our patient. She is hemodynamically stable. We determined that from a Wells criteria standpoint, she had a high probability for PE. We're reassured that her BUN and creatinine are within normal limits. You ask her allergies, and she says she has no allergies at all. She has no history of a contrast allergy, so what do we do next? Well, we have some options. We would get basic laboratory studies. Maybe the ER doctors probably already ordered some of her laboratory studies, but we would finish her workup. We'd want things like a CBC to make sure she doesn't have a profound thrombocytopenia. We'd want baseline coags. An EKG we can consider. Radiographic studies, our options are VQ scan, CTA of the chest, MRA, and an angiogram. Now, we all remember from PA school and NP school that pulmonary angiogram is considered the gold standard for diagnosing, but we will find that CTA of the chest is actually fairly good for ruling out PEs and has a negative and positive predictive value that's pretty close to angiograms. So that's now considered the standard of care. So CT angiogram, what's the evidence? We briefly brought up the PIOPED studies, but PIOPED 2 specifically looked at CTA of the chest. And they found that in patients who had a low intermediate probability and a normal CT angiogram of the chest, there was an 89 to 96% negative predictive value. In patients who had intermediate or high pretest probability with an abnormal CTA, the positive predictive value was 92 to 96%. So if you can't get a CT scan for a while, it is reasonable and recommended that you'd start the patient on treatment with anticoagulation while you're waiting for these test results to come back. But a CT scan currently is considered the standard of care. Now, when you may not be able, we'll talk about VQ scans in just a minute. Multi-detector CT angiogram is operator dependent. In the ICU now, I do get a lot of suboptimal studies back on CT angiograms just because they can't always time and have the patient hold their breath when they scan them when they're on a ventilator and sedated. But the results are operator dependent. If you have a suboptimal study for PE and you're highly suspect the patient has one, you may need to repeat the study or treat them. Now, contrast exposure is a risk. So no one, and like Dr. Summers was talking about this morning, the longer you're in practice, the more you think about these things, but no one wants to cause contrast nephropathy. So think about that. If you have time, give them IV fluids to decrease their risk of ATN from contrast and whatnot. And remember, you can't use CT angiograms if the patients do have a contrast allergy. Prepping them with steroids takes hours to do, especially if they have a history of very severe allergy. So if they have kidney failure, if they are allergic to contrast, you can get a VQ scan. And sometimes you will often use a Doppler ultrasound with that as well. Now, VQ scans, when the PIOPED-1 study looked at VQ scans, they found that high probability VQ scans, everyone, you probably know this already, but with VQ scans, you get them back as either low, intermediate, or high probability. They don't come back like CTA scans and say, yes, there's definitely a PE in this area. So if you have a high probability VQ scans on pulmonary angiography, 88% of those patients had a PE. On the low VQ scan, when you get it back and it comes back as a low probability, only 33% of those patients had PEs on pulmonary angiography. So CT scan is still preferred, but VQ scan can be helpful in that setting if you can't use contrast or they have renal failure. And you can couple that with a Doppler ultrasound to try to help you should the patient's VQ scan come back as intermediate. It never usually helps anyone when that happens. But Doppler ultrasound may help you if that patient has a large lower extremity DVT, then in an intermediate VQ scan, then they could have a PE as well. So you would initiate treatment and go from there. Okay. So the PIOPED-2 study also looked at D-dimers, and they found that patients who had low or moderate probability could start with a D-dimer, and if it was negative, you wouldn't have to further treat. If it was positive, then you would treat. Now, our patient, we know, has a high pretest probability, so we're going to proceed to treatment and not get a D-dimer because she's not at a low or moderate risk probability. For patients who are, however, if they come back and have a D-dimer that's positive and have a negative CT scan, they don't need any further workup. However, if their CT scan's positive, you would start them on treatment. So this basically summarizes what we just talked about. But if your CTA comes back negative and you have a very high clinical suspicion, I mean, we've been talking all about probabilities and whatnot, but your clinical judgment is always going to outweigh any score, right? So if you have a high clinical suspicion, you calculated a high probability, you go to CT scan, the CT scan comes back negative, your options are to repeat the CT scan if it comes back, like I talked about, one of those suboptimal PE studies, or you could consider an ultrasound of the lower extremities. Serial ultrasounds, MR venography is an option, although it's quite costly and can be very operator dependent if you're ordering it in a facility that doesn't do these often. And pulmonary angiogram is invasive and whatnot, but that would be probably a last resort. Now back to our patient. She has high probability, so we decided we don't need a D-dimer. We get her CT scan, and her results come back positive. So what are we going to do to treat her? Well, we'll talk about that in just a little bit. But there's her PE and her CT scan. So the other options to finish her evaluation, if we're going to do this thoroughly, is to get a troponin. And the ER already did. We know that it's mildly elevated at 0.03, not entirely uncommon for patients who present with PEs to have mildly elevated trop. We can consider an ABG. If you get an ABG, you'd expect to see in severe, if they have some hypoxia, a hypoxemic result on your ABG. But you also can see really high AA gradients. And sometimes if I'm waiting for the result to come back and trying to put the pieces of the puzzle together, if I get an ABG and I see that their AA gradient is 600 and they have no other reason to have an elevated AA gradient, that helps me because it helps me start to think maybe this is a patient I need to start treating while I'm waiting for the results of the CT scan to come back. An echocardiogram is also helpful. It helps to further evaluate possibly the degree of RV or right-sided heart failure that may be occurring in the setting of the PE. And a VQ perfusion scan, when a CT is contraindicated, if the VQ is intermediate, definitely check a lower extremity Doppler ultrasound. If the Doppler is negative, you could withhold on anticoagulation. EKGs. So 97% of patients have an abnormality on their EKG when they come in with PE. And in my experience, this correlates. Most commonly, you'll see sinus tachycardia. You can see right bundle branch blocks. Nonspecific T-wave changes are common to see as well. But atrial fibrillation is another big one to remember. If I have a patient, I actually got called to see a patient as a rapid response a few days ago who had atrial fibrillation with RVR. Her rates were in the 180s. And No one had ruled her out for PE. Now, this was a new diagnosis of atrial fibrillation, and if your patient is coming in with uncontrolled rates and never having been diagnosed with atrial fibrillation before, a PE study is very, very reasonable. Now, I also think of PEs in patients who have chronic atrial fibrillation, but if they have rapid ventricular response, it's not responding to treatment, then that's also another time to think about maybe this could be a PE. Classic EKG findings, S1Q3T3 pattern. I've lucked out because all the times I've seen this, I've actually had a student with me, and I have seen it a handful of times, although it's not very common, is indicative of right heart strain. So if you see that on an EKG, you know that the patient does have right heart strain. Now, troponins are helpful for prognostication. If your patient does have a markedly elevated troponin, their fare or their outcome from their PE is not going to be as good as a patient who has a normal trope. Echo poor outcome predictors. RV hypokinesis is a poor outcome predictor, as is pulmonary hypertension. And right heart thrombus is also a poor outcome predictor as well. Now, if a PE is confirmed, do we need to go after a DVT and get an ultrasound? I've always worked in academic medical centers, so sometimes we just justify our desire to look for it by saying, oh, it's for academic purposes, we'll go ahead and get it. But perhaps we should be a little bit more pursuant of getting that, because 51% of patients who have confirmed PEs also have DVTs. Now, at 3-month follow-up, the mortality rate was higher in the patients with DVTs, 15% as opposed to 6% in this study. But whether or not that was an all-cause related death versus recurrent PE versus recurrent VTE, they couldn't ascertain. So treatment duration remains unclear if there is both, but that is something to be mindful of. Perhaps we need to be more cognizant in thinking about getting ultrasounds after we do PE studies. You could argue that it doesn't really change things, but something to think about. Now, let's get into the treatment of acute PE. Now, the guidelines, we're going to spend most of our time talking about pharmacologic management, because non-pharmacologic management is not currently the main recommendations from the American College of Chest Physicians. Non-pharmacologic management is not considered first line. So stable versus unstable patients who come in with acute PEs, we'll talk about how that what the treatment options are based on whether or not they're stable or unstable, and whether or not some people can go home and some people can't. And then we'll also briefly talk about thrombolytics. Now, general guidelines are similar to the recommendations for DVT. Your options for starting treatment are Lovenox. You can use fondaparinux if patients have a history of heparin-induced thrombocytopenia. Those are the preferred agents for first line in patients who come in with PE. Warfarin's initiated on first treatment day. Lovenox or IV unfractionated heparin can be discontinued once there's a stable INR above 2. The NOACs we'll talk about. And obviously, all those patients, you're going to want to see a baseline CBC and coags if indicated. The CBC, we're interested in seeing if this patient has a hemoglobin of 6. We need to have a talk before we start them on huge doses of anticoagulation. But coags are also helpful just to get baseline studies. Okay, so stable versus unstable patients. Stable patients can be treated as an outpatient with NOACs or Lovenox, Coumadin Bridge, or fondaparinux. Now, some patients who you are worried about compliance or have complicated social issues, or even patients that something's just not right and you want to admit them for a 24-hour observation, it's perfectly reasonable, and that's fine. Patients who are unstable are patients who have shock or hypotension that's persistent, and systemic thrombolytics are recommended, and if those are contraindicated, then you're going to be considering an embolectomy. Now, this is a score that I have found useful in my practice. It's used widely in Europe. It was a score that was validated by enrolling over 15,000 patients. There were 180 centers that they looked at, so that limited the bias. But the pulmonary embolism severity index score helps to determine the risk of complications and mortality. And it's similar to the Wells score in that you assign them a point based on their clinical findings, and then higher scores are correlated directly with higher rates of mortality. So if you're in the ER and you're not quite sure whether or not this is a patient who needs to come into the hospital, it may be helpful. You may be able to use this score to combine with your clinical judgment as to whether or not this patient should come into the hospital or not. Now back to our patient. She's 3 weeks out of surgery. We've determined that she has a transient risk factor, so we're going to treat her for a 3-month period. We admit her, start her on some oxygen as needed. We can use compression stockings if she needs it. And then when we're getting our thorough history, we find out that she's actually planning a trip to Kenya in 4 weeks. This is why we should always have social histories, new social histories on hand, right? Okay. So what are our options? So we have the NOACs, we have heparin, Lovenox bridge with Coumadin. And the other thing I'd add at this point is that it also can depend on the surgeon. Probably a lot of you have surgical experience and know that anticoagulations are a big, put their hands up if we talk about anticoagulation. But something to consider, because the surgeon may have a preference as to what he wants the patient on. So out of courtesy and for the patient's care, coordination of care, it's a good idea to talk with them. So let's just talk briefly, too, about systemic thrombolytics. Now, I work in the ICU, and we get consulted frequently for consideration of thrombolytic therapy. As a hospitalist, PA, NP, in general, you would not be the ones giving thrombolytics. Now, thrombolytics that are approved for lysis of clots are TPA, or tissue plasminogen activator, streptokinase, and urokinase. And they're given over a 2-hour infusion time. But immediately following that, we start them on anticoagulation. So the indications are hemodynamic instability. And the thing I would caution you about is that we kind of tend to jump on this. I've seen it now on the ICU side often. And it seems like a trigger's pulled pretty often for wanting to give thrombolytics. But the ramifications of giving thrombolytics are great. Patients can have retroperitoneal bleeds, intracranial bleeds. I've seen bleeding through the eye that ended up causing blindness. So it's not just easily decided to give someone thrombolytics. It's usually weighing the risks and benefits quite heavily. And a lot of patients, because the indication is for hypotension, you can consider thrombolytics. But I would argue that a lot of the hypotension I see in patients with PEs is transient. So give them IV fluids and see if they respond. If they respond, we're not going to be giving them thrombolytic therapy. And usually thrombolytic therapy, when we see profound hypotension from PEs, are patients with huge saddle PEs who also are progressing towards the need for mechanical ventilation. So remember that the patients still need anticoagulation following administration, so start them on anticoagulation, give them some fluids if they're hypotensive, and then call the ICU, and then we'll decide whether or not the patient should be given thrombolytics or not. Now, the other reason I see the consults put in for ICU in patients who have PEs is because they have profound RV dysfunction. And the studies actually show that patients who are given thrombolytic therapy who have RV dysfunction actually have higher rates of mortality. So RV dysfunction is not an indication for thrombolytic therapy alone. The other thing that needs to be further looked at is extensive clot burden. And the studies I've looked at also show higher risk of mortality with extensive clot burden. So in the absence of hypotension, RV dysfunction and extensive clot burden are not indications for thrombolytics. Okay, so you'll recall this slide probably from a little bit earlier, but the good news is it's the same. And so find out the etiology for the PE and treat accordingly in terms of duration based on their risk factors. Now, non-vitamin K oral anticoagulants. This is kind of exciting because NOACs now, according to the American College of Chest Physicians, the most recent, the 16th edition was just published a few months ago, they now recommend NOACs over warfarin. So our options are direct thrombin inhibitor, there's only one, dabigatran, direct factor 10A inhibitors. There's rivaroxaban, apixaban, and edoxaban is the most recent FDA approved. That was approved in January 2015. So those are our options for non-vitamin K oral anticoagulation. Now, how do they work? Well, factor 10A inhibitors work directly on factor 10A. You can recall, according with the coagulation cascade, that factor 10A converts prothrombin to thrombin. And then direct thrombin inhibitors work directly on thrombin to prevent the conversion to fibrin. And fibrin is the end stage in the coagulation cascade when the clot becomes that fine mesh-like, glue-like, sticky substance that makes it a clot. So non-vitamin K oral anticoagulants are NOACs. The latest chest guidelines suggest using a NOAC over traditional therapy. Now, it's a grade 2B recommendation, likely because they haven't been around that long, so there is a lack of long-term safety data available. So you can think of grade 2B, there's ways to look at, the letter and the number, but think of it as being a moderate evidence-based support of using a NOAC over traditional therapy. The thing to recall is that it's not recommended to be used in patients with malignancy. Patients with malignancy who have a clot get Lovenox. You want to avoid it in pregnancy and also in renal insufficiency. So the pearls with NOACs are that the overall bleeding risk is not actually higher than when it was compared with warfarin or vitamin K antagonists. They have short half-lives. Their half-lives range between 5 and 17 hours, as opposed to Coumadin. If we stopped Coumadin and didn't reverse it, it would be about a 40-hour half-life. So their half-lives are much shorter. They're easier to take because they're fixed doses. You're not changing the dose all the time. There's fixed doses with a faster onset of action than Coumadin. And there are fewer drug-to-drug and food-drug interactions. Now, all patients should have baseline coags and a serum creatinine drawn prior to starting this treatment. And you may need to either dose reduce or discontinue in renal failure because none of the studies that looked at these included anyone that was on dialysis. So you may have to dose reduce. Now, what's limiting them right now is the lack of long-term safety data. They're expensive, and there's just an overall general unfamiliarity with this as opposed to Coumadin that's been around for decades. Now, dabigatran, or Pradaxa, the indications, it is FDA approved for DVT and PE, both treatment and prevention. And it's a potential option in the future for treatment of hip thrombosis, although that is not FDA approved, so I just put that in there because maybe next year we'll be talking about that. But patients who have any kind of GERD or heartburn-like symptoms probably will not tolerate dabigatran. That was its #1 adverse effect, was that it worsened people's GERD. It has a tartaric acid core, so it's poorly tolerated in people with dyspepsia or GERD. Major bleeding events were similar when compared with conventional treatment, and it was actually found to be more effective than conventional therapy in prevention of systemic embolism. Now, the other thing with NOACs that we get worried about is that there's no antidote for reversal, but there is an FDA-approved monoclonal antibody that's directed exactly towards dabigatran. The antidote is called iraducimab, and dabigatran can also be reversed via dialysis. None of the other NOACs can. So if it can be reversed via dialysis and there is an antidote, there may be a little bit more or reassurance in starting people on this therapy. But recall that the major bleeding events were actually similar when they compared it with conventional treatment. So rivaroxaban, apixaban, and you could group edoxaban into this as well. If you want to look further, apixaban was further studied by the Amplify trial and rivaroxaban by the Einstein trial. But they're both FDA approved for DVT treatment and prevention, DVT and PE treatment and prevention. The major bleeding events were similar also when compared with conventional treatment. Now, unlike dabigatran, these were not found to be superior or inferior to conventional therapy in prevention of VTE risk and death. But you do have to use caution when these patients have hepatic impairment or renal impairment. So there is dose reduction if they have significant renal impairment, there's dose reduction that's needed if they have just a mild change in their creatinine, but you need to avoid it if there's significant renal impairment. Now, bleeding risk is something we always have to think about when we're talking about anticoagulation, and the bleeding risk is highly associated with age. The risk increases by 40% per 10 years of age increase, which is quite profound. And you think of patients on vitamin K antagonists and their risks of bleeding as being pretty high, but as far as major bleeding events per year, it's actually just 2 to 3%. But minor bleeding is a little bit more common. So the bottom line is that elderly patients have the highest risk of thrombotic events and of anticoagulate associated bleeding. So they're not really out of the woods in either setting. They're either going to have a higher risk of VTE or they're going to have a higher risk of bleeding. And this is where sitting down with your patient, sitting down with the family, sitting down with the other providers taking care of the patients, where everyone may have an opinion, and we can't really approach all patients as having this one drug fits all approach. Rather, thinking about their risk of bleeding and their other comorbidities may help direct us towards which agent to use. But I thought this quote was a good one. An individual case-by-case approach might be best for elderly patients with proper judgment of risk of bleeding and associated comorbidities rather than a generalized one-drug-fits-all approach. Now back to our patient. She was admitted and she was started on a heparin drip as we tried to get in touch with her surgeon just to make sure that he was okay with everything that we were doing and if he had any other input. And because of her anticipated travel plans, her normal renal function, and her low postoperative bleeding risk, her heparin was discontinued and the patient was started on rivaroxaban. We didn't really feel too comfortable deferring INR testing to medical centers in Kenya, although she assured us that it would be no problem at all. So we thought it was best if we put her on something with a little bit more of a steady state and less drug interactions and food interactions and everything like that. Okay, so what are some of our non-pharmacologic options? Well, mechanical thrombectomy and catheter-directed thrombolysis are reserved for patients who have a high risk of disabling post-thrombotic syndrome. And also, I'll add, are reserved for patients who have contraindications to anticoagulation. Systemic anticoagulation, according to the American College of Chest Physicians, is the #1 thing to go to. However, if your patient is also going to have a high risk of disabling issues following the diagnosis of their clot, considering mechanical thrombectomy or catheter-directed thrombolysis is a reasonable option. Now, IVC filters have been put in more and more and more frequently over the last several years, and I'm not seeing as many permanent filters as I am temporary or retrievable filters being put in, which is good because permanent IVC filters actually increase your risk of clot later on. So those patients, although they may not be on anticoagulation when the clot is placed, or when the IVC filter is placed, they will need anticoagulation later if it's not retrieved. And the longer it stays in there, the more difficult it can be to remove it. So an IVC filter is indicated for patients who have an absolute contraindication to anticoagulation. And it depends on who you ask, and it depends on what studies you're looking at. Because according to the American College of Chest Physicians, IVC filters are rarely indicated. If you look at the Interventional Radiology Society, their journal articles suggest that anybody who has a PE and concomitant DVTs, they are patients that should have an IVC filter. So it depends on where you look, but I consider IVC filters in patients that I'm worried about tolerating another pulmonary event. So if I have a patient who has a very tenuous pulmonary status and has a large lower extremity DVT, they already have a PE and the PE's already thrown them over and they're kind of teetering, those are patients I start thinking about IVC filters on. So something to think about there. So we're going to conclude with this case, and then there's a couple special considerations I just wanted to update you all about. So we're almost done. But this is an 85-year-old female who presents with a history of prior PE in moderate respiratory distress. Her vital signs show that she's tachypnic. Her blood pressure is 95/64. Her heart rate is 110. Her exam shows that she has JVD. She has 2+ pitting edema, the lower extremities. Her cardiac enzymes show that she's a little elevated. Her trope is 0.06. Her creatinine is normal. Her BNP is 502. Her chest x-ray is unrevealing, and her EKG shows atrial fibrillation with some non-ST changes. So which of the following is the most appropriate next step in this patient's evaluation? Is it order a CT scan of the chest with PE protocol, echo, and start IV unfractionated heparin? Is it to order a D-dimer? And then if that's positive, get a CT chest with PE protocol? Is it to give thrombolytics or discharge the patient to home with Lovenox and follow up in the anticoagulation clinic? I thought there would be some people choosing C, and there's not. That's great. So yes, I agree with you. A is the answer. Order a stat CT of the chest with PE protocol, echo, and start IV unfractionated heparin. So why is it not B? The answer is not B because looking at this patient who is hypotensive, tachycardic, has some signs already suggestive of RV dysfunction or failure, we're thinking our first and primary diagnosis is a PE. So are we going to stop and wait for the D-dimer to come back and then get a CT scan? We're probably not going to wait for the D-dimer to come back because our first and most likely diagnosis is PE. So it would be appropriate, because that is your leading diagnosis, to start her on heparin, get the CT scan, and then adjust accordingly afterwards. All right. So isolated distal DVT, there's a questionable role of D-dimer. Without symptoms or risk factors, you can do serial imaging in 1 to 2 weeks. Most clots, if they're going to propagate, will propagate within a 2-week time. And then you can treat them if they end up coming back. Now, if they're symptomatic or they're high risk, you treat for 3 months' time. Oh, and I'm just going to add, let's see, what does this say? Isolated. This is distal. So superficial femoral vein is part of the deep venous system. This is not a distal DVT. That would be a proximal DVT. But superficial femoral vein, I wanted to remind everyone, is part of the deep venous system. So don't be fooled by its name. If you get an ultrasound back and there's a clot in the superficial femoral vein, it needs to be treated because it's part of the deep venous system. Okay, treatment duration in cancer patients. Now this is kind of interesting. Again, you have to kind of weigh the risks and benefits here. Are you going to keep someone on anticoagulation because the guidelines say extended anticoagulation is recommended regardless of bleeding risk? If the patient's hemoglobin is 6 and they have a massive GI bleed and they have metastatic lung cancer. I mean, the answer is no, you're not going to do that, right? But just know that extended anticoagulation is recommended once their bleeding has been stabilized. And these patients, you may have to monitor their hemoglobin more closely and have close follow-up and whatnot. But regardless of bleeding risk, extended anticoagulation is recommended because their risk of clot is so high. Anticoagulants should be continued until there's no evidence of active cancer, and until the patient has been off of treatment for 6 months' time. So I think in reality, I'm not sure we practice by these guidelines in general, but those are the guidelines currently. Catheter-associated upper extremity DVT, I see this all the time in the ICU. This is why part of the reason that we're so hesitant to take people off of prophylaxis in the ICU setting is because of things like this. They can have profound upper extremity swelling and pain and redness and discomfort because of these catheter-associated upper extremity DVTs. Now, treatment's indicated for 3 months, and as long as the catheter remains in place. And the catheter actually doesn't have to be removed if it's being used for clinical care and it's functional. The nurses can draw back and whatnot. You can keep it in as long as you start them on treatment. Prophylaxis not recommended. They're referring to patients who go outside of the hospital setting with a PICC line in, getting an infusion of something, not patients in the inpatient setting. I should add that to the slide so it's clearer. Superficial vein thrombosis. Now you treat if it exceeds 5 centimeters. The options for treating are fondaparinux or Lovenox for 45 days time. NSAIDs can help with pain control, but you really don't treat these unless these are large in size. So general medical patients and VTE prophylaxis, what do we use? Pharmacologic prophylaxis is ultimately recommended, although we know that if your patient comes, you have a patient who has a GI bleed or something along the bleeding lines, we're not going to use pharmacologic prophylaxis, but that is best if you can use it and it's safe. And the prophylactic dose of Lovenox, I'll be at 40 milligrams per day, or 30 milligrams if you have a smaller, frail person per day, is preferred over unfractionated heparin TID, which is preferred over unfractionated heparin BID. Fondaparinol is also fine. If your patient has a history of HIT, that's what you would be using. DVT prophylaxis for low-risk patients. You can use mechanical prophylaxis, so TED hose, SCDs, have them get up and walk. I always tell my patients to get up and walk when they can. High-risk patients, pharmacologic prophylaxis is recommended. And then, of course, when their bleeding risk is outweighing the benefit, you want to use mechanical prophylaxis. So take-home points, you want to suspect PE for patients with dyspnea, pleuritic chest pain, and tachypnea. Use a clinical suspicion tool, but remember your clinical judgment is always going to outweigh any kind of score you're going to use. So use it judiciously, but you can use it to develop a pretest probability for patients with suspected VTE. Categorize patients as unstable versus stable, and then take the next appropriate step in their treatment plan. And remember that the length of anticoagulation is dependent on the etiology of VTE. I know when I first started practicing, we treated PEs for 6 months and DVTs for 3 months, but that's no longer the recommendation. So find out the cause and then treat accordingly. So I have a flight to catch, but I am available for some questions in the back if there's anyone who does have any questions or comments or ideas on how I can make this presentation better. There's my email address if you have anything else to say. So thanks for your attention. I hope the rest of the conference goes well.